Hi everybody, it's Susan Roberts, and today we're talking about medication errors and risk reduction. The first thing I'd like for you to do is to look in your book, in your chapter, and look at the learning outcomes. This is what we're going to be hoping will happen by the end of the review of this chapter today. So we'll be looking at defining what a med error is. We're going to look at factors that contribute to medication errors. We will look at med errors and their impact on patients and healthcare facilities. We're going to talk about methods for reporting errors and strategies that we can use to eliminate errors. We'll talk about medication reconciliation, which was one of our safety goals that we learned a long time ago. We're going to look at teaching information to reduce med errors in our patients when they go home. We'll look at strategies by healthcare organizations, so our hospitals, in trying to reduce med errors. And then finally, we'll look at governmental and national agencies and their tracking systems that look at med errors. So back in the day when I was a nurse, we were way more at risk for medication errors. We had the old-fashioned cart, and it had the little drawers with your patient name. And we would open up the drawer and reach in and use a MAR and then pick out the medications that we needed. And we'd put them in a little pill container and paper cup, and we would take them to the bedside and we would check their name band. But we had a lot of medication errors in that day and age. And now we have so many new protocols and policies in place that actually reduce med errors. And we have our Pyxis, and it's all computerized. We have to do 3 safety checks and 2 forms of ID. When we scan a med, there's a little barcode on it, and it'll tell you that's the wrong med, or are you sure you only have 1, you really need 2, is this the right patient, etc. So it's almost really hard to make a med error these days, but they still happen. And it's all about patient safety in clinical practice. We want to be 100% accurate. You know, when we have you take those math calc exams, we know you guys all hate those. And, you know, we're really only asking you to be 90% correct. But do you really want to go up to your patient and say, well, 10% of you I'm going to make a med error on because I only got 90%. So of course we want 100% accuracy when administering medications. But we know that there's a lot of complex steps that take place, and patients are different. We have immunocompromised and elderly and people that are just really sick. So we're always looking at strategies that we can use to make medication administration safer for all of our patients. What is the definition of a medication error? So we have the National Coordinating Council for Medication Error Reporting and Prevention, and that is the NCCMERP. They describe a medication error as any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. So they're also looking at when we give these medications to our patients and send them home. Did we do proper discharge planning and education? Did we give them the information on the med? Are they going to go home and forget all about what we instructed them and miss a med or take 2 meds, take the wrong med or something like that? So it isn't just the healthcare provider, it isn't just nurses, it's our patients and consumers as well. What are 2 causes of medication errors? Well, I want you to sit and think, and I know you guys know, because you've probably been around the hospital already and you're already thinking about, some of you are LVNs, some of you are RNs for first time, but there's a lot of things that can cause medication errors. And so my answer to that is there are dozens of things, so let's talk about them. There are med errors from physicians and nurses and pharmacists all the way down the line. Okay, so with physicians you might have illegible handwriting. Well, should the pharmacist fill orders anymore, or should we write down the orders and take them off on the chart when a physician uses terrible handwriting? We can't read it? Of course not. Remember those problems we had with the leading and trailing zeros. Okay, you had a trailing 0, 5.0, the next nurse recognized it as 50, okay, instead of 5 milligrams. Okay, and we had a 0.6 7 milligrams, and the nurse saw it as 7 because didn't see the little point. So if we put the 0 point, we always know there's a decimal there, and we never use a trailing 0. Okay, sometimes we misinterpret abbreviations. QD had a big problem. QOD, people misinterpreted as every day when it was supposed to be every other day. So there's a lot of those. The U for units we used to use. We'd put 1 U, and if the U was sloppy, it could look like a 1-0, like a 10, and somebody would give 10 units of insulin instead of 1. So now you have to write out units. You have to write out daily. Okay, we might have incomplete medication orders. Well, how can you give a medication if something is missing, either the time, the frequency, the milligrams, the route, etc. Inappropriate prescribing of the drug. So maybe the wrong person is prescribing the drug. Failure to follow the 5 rights and 3 safety checks. So this nurse is saying, I hope 2 safety checks is enough. And so of course that's to get you guys to say, no, it's supposed to be 3. We should pay attention to expiration dates. Sometimes we get the wrong patient ID. I've told the story about the 2 ladies in the skilled nursing facility, the SNF, bed A and bed B, and the 2 women decide to switch places because bed A doesn't like being by the window, but bed B does. So they switch, and what does the nurse do? Come in and give meds to bed A, but it's really the lady from bed B. So we don't use beds anymore. You've got to use 2 patient forms of ID. Their name, their birth date, their the MAR record number. And sometimes we give the wrong dose. I've seen the wrong med taken from the drawer. It looks like a little white pill, and we pulled the pill out and it's in the unit dose, and we didn't read the package. So that's a wrong med. I've also seen a nurse give a patient the wrong med because it was 2 Advair discuses sitting in the top drawer of the unit, and the nurse pulled out Mrs. Smith's instead of Mr. Jones, and so that's considered a med error, even though the med was really the same. But who wants to put their mouth around a little discus and inhale it if it really belongs to somebody else? I have this Mosby Preventing Med Errors, and if you guys are still getting those DVDs and you have access to those, watch the one on med errors. It's going to really help you for your exams. Here's a question for you. Should a parenteral syringe be used to prepare oral liquid products? And the answer is yes or no. Which one do you choose? And the answer is no. So take a look at this picture. On top, we have a parenteral syringe. It's got the luer lock. It screws on. You can put it in the hub of the IV and push it in and screw it on and deliver your IV med. The bottom one is for oral. It doesn't have a luer lock. You cannot put this in an IV hub. So, if you are going to give something orally, do not put it in a parenteral syringe, because what's happened, I know it sounds remote and crazy, but nurses have gone in the room for oral meds in an IV syringe, went over, got distracted, and put the med in the IV. And we've had some deaths that way. So you can go to this nurse advised error. This was in April 2010 when this medication error happened. It was on a child, unfortunately. So that's why I take a look at these and encourage you always just to use an oral syringe for oral products. That way you can't make a mistake. Now take a look at handwriting errors. So this was mentioned as one of the contributing factors. This is definitely impossible to read. The top one is impossible. The bottom one I can maybe read is Phenergon 5 cc's, and we're not supposed to use cc's, right? We're supposed to use mils. POBID, maybe per 1 month. I don't know. So I'm certainly not going to try and take that order down, and I'm going to call the doctor and get it clarified. Is this a med error? It's 9 o'clock. The order is for potassium phosphate, 7.1 milliequivalents every morning. Now remember, the nurses put whatever they think is mornings, usually about 9 o'clock med times. The doctors don't put that usually. or you also have an order, potassium chloride 20 milliequivalents, PRN, for potassium less than 3.4. It's 9 o'clock, and what was given is potassium chloride 20 milliequivalents. So would you consider this a med error, and why? Okay, so it's 9 o'clock and the main order is for the potassium phosphate every morning. That's what should have been given. The only reason you'd give the potassium chloride is if you looked at labs and the potassium was less than 3.4. So this would be considered a med error. Probably not going to hurt the patient, it's just potassium, but it is still wrong, it's still incorrect. So you may want to, or you would want to write up an incident report on it. Now, what are some factors contributing to med errors by the healthcare provider? That's us, that's nurses, that's pharmacists. So it would be omitting one of the 5 rights: right person, patient, right drug, right time, right route, right amount, failure to perform an agency system check, failing to take into account client variables like their age, their body size, and we're responsible for that. If we get a big morphine order and we have a little tiny frail elderly lady and we don't think she can handle it, we need to speak up and question that. Okay, and what about people with renal problems or liver problems? Okay, they're not going to excrete these drugs. They're not going to metabolize them in the liver. They're not going to excrete them through the renal. So things can build up. So be careful with, you get an Ambien order and somebody's got liver or renal, they're going to get way too much of the drug, be way too over-sedated. Giving medications based on verbal orders or phone orders that are not documented. So they get 24 hours, they have to come in and write those down and sign off. Okay, practicing under stressful work conditions, what does that do? Well, they've done the research and they found out that there's a correlation between the number of errors with the stress level of nurses or overworked nurses, especially if there's a nursing shortage and the nurses are taking too many patients. There's definitely a correlation with errors. They increase. So that's why that Senate bill was aimed at controlling the nurse-patient ratio so that we didn't get so many patients and would hopefully have fewer errors. Another, misreading the order or writing a sloppy order, using words from the do not use list. Okay, so we should be using these tall man letters that show words that, names of drugs that are very similar. Now, what are some factors that are contributed to by the client? So the clients can cause med errors as well. Okay, so they're doctor shopping, or they're going to different pharmacies, or they're not filling their prescriptions, or not refilling them when they're supposed to, taking the meds incorrectly, taking ones that are left over from an illness before. We all do that a little bit, the antibiotics. I know I'm guilty of opening up my cupboard and there's a few little jars of leftover antibiotics. And also taking medications prescribed for something else. And that would be totally wrong, just people deciding, oh, this might help with this particular thing, it worked for that. Then we have the impact of medication errors. Okay, so it's really huge out there, and we've got Medicare now, the reimbursement being predicated on, are we making med errors? So they lead to morbidity, which is illness, and preventable death. They cause emotionally devastating problems for nurses and the client when it occurs, especially if there's big harm done. They increase costs on hospital stay, lengthy hospital stays. The hospital will get a poor reputation, might even be shut down, and the administrative staff might be penalized as well. So, so med errors are very, very important to try and avoid for these reasons as well. So what are some examples of common errors? What's happened out there? And here's this guy saying, hey, that wasn't my Advair. Well, that was the med error where the nurse picked up the other patient's Advair and gave it to this patient. It already occurred, so the patient already used it. Okay, so let's just take a look at some of those. So giving an incorrect dose or the wrong route, omitting an ordered dose, giving an unordered drug, like, oh, you have a headache? Well, there's some Tylenol in the bin. I'll just give you some. No big deal. Not checking the accuracy of a med order, not reviewing a recent client lab data. So they're on gentamicin and they just had gent levels drawn, and you didn't check, but they're in gent toxicity now, and you go and give their IV gentamicin. So that's not good. Not reviewing other pertinent information about their allergies, drugs that shouldn't be given together, like ibuprofen and Coumadin, heparin, Lovenox, things like that. And undocumented verbal or phone orders. Remember, they get the 24 hours and then you have to flag it or call them. Failing to clarify. You're kind of suspicious about an order or a little confused, but you just go ahead and give it. You don't call and check. And then math errors. Okay, so we've all seen what kind of math errors we can make, and so that's one of them that, that's why we give you all these math practice tests so that you can do that. Okay, heparin, there's a bottle of heparin shown here, and remember I've talked about in class before one of the errors I knew about, and it was at one of the hospitals where those little preemie babies were given overdose of heparin. So what happened is there was heparin on the unit, 1,000 units per mil, and another bottle, same color, looked the same, 10,000 units per mil. So I'm the nurse and I get an order for 2,000 units of heparin. And I go over and I see two bottles. Oh, I'll pull it out of the 1,000 units per mil bottle. So I calculate it, desired dose 2,000, overdose on hand 1,000, times the vehicle mil. I'll give 2 mils. But I get distracted and I turn around, and when I turn back, I pick up the 10,000 unit bottle. And I don't do my 3 safety checks, which that would be the second one, going, okay, did I get the right bottle and stuff. Now I drop 2 mils out of the 10,000 mils per unit. And now I'm giving how many mils? 20,000 instead of 2. And so it's a blood thinner. And so what happened is these babies got little bleeds and stuff, and some of them died. So it's a big problem. So what they did is they're doing these safety checks now. They don't even put these 10,000 units on peds floors. They're different colors, so that shouldn't happen again. So you just have to be careful that you're giving all these meds the right way. Another common error, misreading similar drug names. Oxycodone versus Oxycontin, clonazepam versus lorazepam. One of them's Novolog versus Novolin, the insulins. So you see there the tall man letters, Novolog or Novolin. So when you see those, see Novolog, you can't really confuse it with Novolin because you're using those tall man letters at the end. It's signaling to you, hey, this is like another one, be careful. All right. And then the units I already talked about, the 1 unit, and misread as 10 units. Okay, so one example was a pharmacist misreads Equanil, an anti-anxiety agent, usually 1,200 to 1,600 milligrams a day. Misread it as Elavil, which is an antidepressant, 75 milligrams a day. Well, normally, an anti-anxiety, antidepressant, they're kind of used interchangeably, but the dosages are not. So the patient died after receiving 1.2 or 1,200 grams of Elavil, which should have been only 75 milligrams, thought it was Equanil. So gave the Elavil with an Equanil dosing and massive tricyclic toxicity. So that's a bad one. Okay, another tragic error. Okay, there's aminocaproic acid, Amicar, and there's amikacin sulfate, Amikin. So Amicar and Amikin. You can see where they would be confused. Okay, while taking a med or over the phone, nurse mishears the word Amicar, which is a hemostatic, and gives the patient Amikin, an aminoglycoside antibiotic. So one's a drug that stops you from bleeding, and another is an antibiotic. But the dosings are hugely different again. So soon after, the patient got renal damage and is on dialysis. So 500 or 1,000 milligrams Amicar, and gave the patient amikacin, which only should have been 100 milligrams, but gave probably 1,000 milligrams of amikacin. And what's the side effects? Potential ototoxicity and nephrotoxicity. So terrible, terrible error. Normally, it probably wouldn't hurt the patient to get one dose of an antibiotic if they weren't prescribed, but it's the dosing that's the killer. Okay, what is a sentinel event? Is it administration of 40 milligrams of Lasix when 20 milligrams was ordered? Is it administration of 40 milligrams of Lasix at noon instead of the ordered 0900 times? Was it development of a rash after receiving 40 milligrams of Lasix? Or was it an unexpected reaction causing hypovolemia, low potassium, and circulatory collapse? Well, I hope you're going to look at this and right away know the real answer, because it's hypovolemia, low potassium, and circulatory collapse, meaning this patient's crashing on you and they're going to die. Okay, so if you gave double the dose of Lasix, probably not going to hurt that patient. It's going to make them pee a lot, and you'd have to call the doctor. It could make them dehydrated. Or giving it at noon instead of 9, they're just getting it too late. It is a med error. And getting a rash means that they're probably allergic, and so you can stop the drug. Okay, but number 4 is definitely a sentinel event, something that is potentially life-threatening or causing some kind of trauma, serious trauma or harm is a sentinel event. Now, how do we report and document medication errors? So it is the RN's or LVN's responsibility, and so if a med error is made, then we have to report it. And so basically it's not to punish us so much as it is to get it in the database, so that just like with that heparin, if it hadn't been reported, none of those changes would have taken place and we still would have been having neonatal deaths. Okay, so here's this number. You can call this National Coordinating Council. I want to tell you about a story that this nurse reported, and she was a brand new nurse. It was very, very sad. She said, "I made the worst medication error today and feel so horrible about it. I literally wanted to quit the job from sadness and embarrassment. I'm a new nurse and I've only been working about 5 months at a hospital, and I've been a nurse about 10 months. I had a patient on Lasix drip that was 100 mils total volume, 100 milligrams in 90 mils, which calculated out to be given 5 mils per hour. This may sound confusing, but long story short, I infused the medication at 100 mils an hour instead of 5 mils because I was looking at the 100 milligrams and 90 mils. And I was looking at the 100 mils total volume instead of paying attention to the 5 mils like I should have. Me and the charge nurse caught the error, but 75 mils had already gone in a little over 3 hours when this medication should have lasted for 20 hours if it was done correctly. We contacted the doctor and he said to just monitor him. I filled out an incident report and we restarted the infusion at the correct dose. I believe I got confused because of all the different numbers on the IV bag, and I was also very busy that night. The result of this was a critical potassium of 2.1. We luckily had a potassium protocol to start potassium IV 50 mils an hour for 6 bags total and recheck the level. I felt humiliated and so embarrassed. I knew everyone had known my mistake because a random nurse came to me and asked me if I was okay. I knew he was asking this because the charge nurse must have told him. I felt so dumb and incompetent. I don't know how I'm going to face work tomorrow. Not to mention, we do this thing called lineup at the start of shift where we discuss things that are going on in the hospital unit and mistakes that nurses have made. Although they don't say the name of the person who made the mistake, I know everyone will know it's me, and of course I will know it's me they're talking about. What makes it even worse is that they read the same scenarios in the lineup every day until a new situation happens that they can add to the lineup discussion. I will be so embarrassed every time they talk about this. I feel like the worst person and nurse ever. I still don't know what penalty I will face yet, but I'm praying I don't get fired. Lastly, the worst part of this situation is when it was time to hang the potassium, my charge nurse caught me off guard because I was already anxious and nervous, and she asked me what I would run the potassium at if it was 50 mils per hour. Just to be sure I would hang it correctly, I accidentally said 25 mils instead of 50 because I got really nervous when I'm caught on the spot and asked questions. I'm sure she thinks I'm a complete idiot. I feel like my life is ruined. I don't know what to do. What if nursing just isn't the profession for me after I've worked so hard for it? I'm so distraught. So anyway, it just shows you how badly a nurse can feel when he or she makes a med error. And so it's up to us to not blame and shame, but to help them through this and to know that it could happen by the grace of God to any of us. And so that's why we teachers always go with our students when they give meds, because we don't want a med error to occur or to have you live with that. But if you do your 3 safety checks and your 5 rights, then the chances are minimized that you'll make an error. Very sad situation, isn't it? Now this is a picture that you have in your book, and it's an index for categorizing med errors, and it's based on an algorithm. So basically the reason for this is to look at the harm, the monitoring, and intervention that's going on. And so you want to look at, if a med error was made, the circumstances that led to the med error. So you do this algorithm. So did an actual med error occur? If no, then you're kind of out of it. If yes, go down to the next. Did the error reach the patient? If yes, did the error contribute or result in patient death? If yes, you go to category 1. And then if no, was the patient harmed? If they didn't die, were they harmed? Was the intervention to preclude harm or extra monitoring required? And then if yes, they were harmed, did the error require additional intervention or life-sustaining things? If yes, was the harm permanent? So anyway, they go through this whole protocol, and I know Tri-City just put in one, and their whole premise is we don't want to blame and shame the nurse. We want to help them. And sometimes it's like, for the nurse, it isn't just that it's a bad nurse. It's there were things that came into play. Was the unit really busy? Did the nurse have all the resources? Was the nurse overworked? Those kinds of things. So anyway, you can follow this this algorithm and to see if you can minimize the errors. Here's another. This is that NCCMERP for category the categories. So here's that category A, circumstances or events that have capacity to cause error. Category B, an error occurred but the error did not reach the patient. Category C, an error occurred that reached the patient but didn't cause harm. Category D, it did cause harm, etc., etc. So it goes all the way through up to category H, an error occurred that required intervention, and then finally category I, an error occurred that may have contributed or resulted in the patient's death. So anyway, it's all about patient harm, and it's all about could something have been done at some point to preclude the harm or the death. So if you make a med error, you have to report and document, and you're going to fill out an incident report. Be very factual about it. Don't use any value judgments. Don't blame it on someone else. Well, the CNA interrupted me and so I got distracted. It's all just to prevent others from making errors, and it goes down to risk management. Okay, and so talk about what interventions were implemented following the error to help the client if they got harmed, and complete the incident report. And remember, the incident report does not go in the chart. You chart the incident itself of what happened in the chart, but you do not say an incident report was completed or filled out. It goes to your supervisor, and it goes down to risk management. Okay, and then copy all the pertinent information. And then these are just ways to follow the nursing process so that we can minimize errors and incidents. So of course it's assessment, planning, implementation, and evaluation. So assessment just goes to the patient that you're checking for allergies and you're knowing all about them. Are they mixing stuff with herbs? What are their physical findings? And did you check their labs first? Okay, and then planning, you're asking the client to participate and following procedures and making sure there's no unclear orders, that everything's very clear. And you can see there on the right how bad that would be to try to follow that sloppy order. Then your implementation, 5 rights, 6, 7, 8 rights. I think there's even 10 rights now. Focusing on your task, no interruption at the Pyxis, no distractions. You shouldn't let anybody come and talk to you or ask you questions while you're at the Pyxis. And you yourself shouldn't ask any nurse while they're at the Pyxis. And all the patient teaching that takes place. It is the rule that as we hand the meds to the patient, we're saying, here is your heart drug or your cardiac drug. This is your diuretic, your Lasix, your water pill. This is your antidepressant, things like that. Then that gives the patient the opportunity to say, oh, my doctor was going to discontinue that Lasix. And then you say, oh, okay, let me go check on it. And then maybe that order was written after you'd already drawn up the drugs. So it was helpful to listen to your patient. And then finally, evaluation. Going back and checking to see that the drugs are working and that there's no adverse effects, or that your pain medication did indeed work and you did a pain scale again. And then the final thing is to reduce the number of medication or errors is using the automated, locked, computerized medication storage areas when you have them. We don't see these in the skilled nursing facilities yet, but they're coming. They're starting to work on them. They're definitely getting computerized. Using your risk management departments, collaborating with nursing and pharmacy. Pharmacists have made mistakes too, sent the wrong drugs. Medication reconciliation, coming from a skilled nursing facility, all the meds that they had at home, just because they came in for a fractured femur, are we also looking at meds for their heart disease? And then always check your elderly. 50% to 70 or 80% of the elderly as they get older are on some kind of medication for chronic illness. So check for that. And then realize that polypharmacy is a common problem where they are just taking so many different drugs, and there might be drug-drug interactions. So it's your responsibility to know all those things. So with that said, lots of responsibility, but gee, just think how much money you're going to be making as a nurse out there. So it's all going to be worth it. So just be very careful out there and do a really good job. I hope you've learned from this review of the chapter, and have a great week out there.